Thank you. So you'll notice there's no chat facility on the webinar. However, if you do have any questions, please write them in the Q&A box, which is shown there with the red arrow on the first toolbar down. And we'll endeavour to answer them during the session. Some will be able to type answers and others will try and answer verbally live. If we are unable to answer your question due to time constraints today, we'll try and follow questions up. If you have any burning questions, do email us. So we've enabled captioning today to maximise accessibility, and we've done that from the back end of Zoom. If you do wish to turn this off, you can do so using the toolbar. So if you look, there's an example there, and it's the second red arrow, shows you how to hide captions if you wish to do so today. So thank you for attending. Next slide, please, Shruti. So today's panelists for this webinar, we've got Karen Hughes, who is our SHOT Operations Manager. We're also joined by Dr. Paula Bolton-Maggs, who is a previous SHOT Medical Director and member of the SHOT Steering Group. We have Dr. Catherine Booth, Consultant Haematologist at NHSBT and Barts Health NHS Trust. We have April Malloy, who's a transfusion practitioner at Scottish National Blood Transfusion Services and NHS National Services Scotland. We have Dr. Jennifer Davis joining us, and Jenny is the UKTLC Deputy Chair, Transfusion Lab Manager at Royal Devon University Healthcare NHS Foundation Trust, and Jenny is also Deputy Chair of the UK Transfusion Laboratory Collaborative and also SHOT Steering Group and Working Expert Group member. Charlotte Silver joins us today also. Charlotte is a patient representative on the SHOT Steering Group. And we also have Anne Davidson, last but not least. Anne is an education lead for Patient Blood Management Practitioner Team at NHS Blood and Transplant. And I didn't introduce myself, sorry. I'm Emma Milser and I'm the SHOT Haemovigilance and Patient Blood Management Specialist. So just to say a huge thank you for joining us. Obviously our work wouldn't be possible without our reporters and followers. And just to provide an outline of today's webinar, we're going to include an overview and background from SHOT, some information around wrong blood in tube events reported to SHOT, so some of the common themes that we see and lessons learnt. Practical steps to ensure accurate patient identification. We're going to include the transfusion practitioner perspective, some laboratory aspects and the patient perspective, and available resources in the UK and conclusions. And then, as I've mentioned, there'll be a Q&A opportunity for all panelists to be able to answer your questions. So is this over to you?
Thank you, Emma.
Thank
you.
Why
are we covering this topic today? There continues to be a common reoccurring theme from the annual SHOT reports where positive patient identification has impacted on transfusion safety. In 2022, there were 6 ABO incompatible transfusions reported in the UK, and these resulted in 2 deaths. 5 of the ABO incompatible transfusions were due to primary clinical errors, 2 were due to collection errors, 2 were due to primary errors in the administration process, and 1 was following a wrong blood in tube error. And 1 originated in the transfusion laboratory where an ABOI plasma component was transfused due to a component selection error. In 2022, 40.7% of all wrong blood in tube errors were attributed to the failure to identify patients correctly at the phlebotomy stage. Overall, 71.8% were attributed to failure to identify the patient at the time of sampling or sampling away from the bedside. 2022 saw a large increase in wrong blood in tube errors, which have the potential to result in ABOI transfusions. 2 deaths occurred in 2022 due to safety checks not being performed during the collection and then subsequently not being performed at the pre-administration check. However, in different circumstances, many more patients could have suffered the same fate. This figure shows a summary of potential outcomes resulting from errors in the transfusion pathway, and that while there were 2 deaths following ABOI, there were several errors with the potential to cause serious patient morbidity and mortality. Next. The lack of reliable, accurate patient identification was noted in the majority of ABOI events. However, other contributing factors, including inadequate resources, knowledge gaps, high workload, decision fatigue, and assumption bias were also contributory factors in a lot of these cases. Next slide, please, Ruthie. One of the main recommendations in the 2019 annual SHOT report was around accurate patient identification. And yet, despite the priority placed on addressing patient identification in previous and current SHOT reports, significant problems persist in clinical and laboratory areas. Accurate patient identification is fundamental to patient safety and must underpin patient care at every stage to ensure a safety-focused culture. I will now pass over to Dr. Paula Bolton-Maggs, who will be discussing ROG blood in tube events and lessons learned.
Thanks very much and welcome to everybody. Next slide, please. So this shows the data from the first SHOT report 25 years ago nearly, and what it shows you is that the majority of problems were caused by incorrect blood component transfused, and a wrong blood in tube resulted in a death from an ABO mismatch. Overall, there were 12 deaths and there were multiple errors in many cases. Next, please. This shows you the 10 steps in transfusion, which involve many different healthcare staff with all the potential to slip up along the way. I'm sure many of you are familiar with this slide. What we see here is the last 7 years, ABO incompatible transfusions, there have been 24. But if you look at the bottom half of the iceberg, you can see that there were more than 2,000 potentially ABO incompatible transfusions that were detected. About 1 in 100 wrong blood in tube samples can result in an incompatible transfusion. Next. This shows, back one. Now, this shows that there were 15 deaths in the first 10 years of SHOT from ABO incompatible transfusions, but only 9 since then. So we have made some major progress. Also note that 2/3 of ABO incompatible transfusions fortunately have no or minor adverse reactions. Next. And as we've already heard, 78% are due to patient identification and sample labeling errors. And in 19% of cases, both those errors occurred together. We could do better. Next. This shows the importance of the pre-administration safety checks. You can see that the majority of these cases could have been detected if the pre-administration checks had been done properly. That's all the red bars, it's the majority. And so it does emphasize how important it is for you to do the checks at the bedside before the patient is transfused. 77% could have been identified at the bedside. This is an example, a case example of how not to do it. The patient was having a top-up blood transfusion, but the nurses took 2 units for 2 different patients at the same time against the electronic prescriptions and gave the units the wrong way around. Fortunately, the alarm on the pump sounded, and then it was realized that the patient was getting the wrong unit. The checks had been done away from the patient's bedside, a checklist had not been used, and the patient was not wearing a wristband. Many errors, as you can see. This just shows, for your reference, the number of different steps we've taken to try and improve transfusion safety. But unfortunately, we still have a very significant number of mistakes being made in the transfusion process, which is partly why we have this webinar today. Next. The sample circle was given to us by a transfusion practitioner, and it demonstrates how important it is to label the patient's samples at the patient's bedside at the time of sampling. Next. I'll now hand over to Dr. Kath Booth to carry on. Thanks.
Thanks, Paula. So we're talking a lot about positive patient identification, but what do we really mean when we say that? People do it badly. And these are some of the common pitfalls. So first of all, make no assumptions and don't put any words into the patient's mouth. We all know that our patients are inclined to agree with the doctor or nurse, so don't make any suggestions to them. Then don't rely on your memory of who the patient is or where they are in the ward, or don't rely on another member of staff to identify them on your behalf. And never use any other aspect of their documentation, or their other kind of paraphernalia to identify them. Next, please. So how should we do it? Now, the clue is in the name. It is positive patient identification. So the patient is the key to this. And you're going to ask them two vital questions. What is your name? What is your date of birth? And they need to independently offer you that information. Then you're going to take that, so you're going to check it against the details on their wristband and check that against any other relevant documentation, which might be the request form for a blood test, might be their prescription chart, the compatibility tag of the unit you're about to hang. And that takes us on nicely to when should we be checking the patient's identity. And I can't emphasize enough that this is in any interaction with your patient. And this isn't just relevant to transfusion, it's any clinical interaction at all. So that means a consultation with the patient, it's taking samples, not just for transfusion, any blood sample. It's giving a drug, administering a blood component. And then it's also anytime you interact with that patient's medical record or their prescription chart, you need to be 100% sure that you are looking at the right patient's documentation. And we do learn this. We learn this at medical school. So this is an example of an OSCE mark sheet. So that's the practical clinical examination that all medical students will do. And every station with a clinical interaction has a mark for introduce yourself to the patient and check the patient's identity. Somehow we lose that knowledge. And I'll be very honest, I don't think I really appreciated as a medical student quite why that was so important. Now, this is patients are key to this. And I think patients have a really important role in promoting their own safety. So we should be empowering patients to ask for their identity to be checked and to challenge if it isn't checked. And when it comes to patient sampling, we should be encouraging patients to check their blood samples after they're taken. You know, who better than the patient themselves to confirm it's correctly labelled? And if we make that a cultural shift, it can make patients feel safer, and there shouldn't be any offence from the person taking the blood. It's reassuring to the blood taker as well to know that that sample is going to be accepted by the lab. Why am I harping on about this? Really, does it matter that much? Well, I'll give you a couple of cautionary tales. The first one is a young lady who'd presented to ED very unwell and was suspected to have a ruptured ectopic pregnancy. And she received various types of treatment in the ED, analgesia, drugs, and 2 units of emergency flying squad ONEG. And she was rushed to the theatre. And it was only as she was being wheeled into the anaesthetic room that her partner said, oh, by the way, that wristband that she's wearing, that's not her name. So clearly nobody at any stage has involved the patient in the positive patient identification process there. The next one is another report from our files. A doctor had decided that patient A needed a blood transfusion. He called the blood bank to order, but unfortunately used the records number of a different patient, patient B, and went and prescribed the unit on patient B's chart. So the ward dutifully collected the unit, hung it up for patient B, and thankfully the doctor was walking past and noticed that a patient who didn't require a transfusion, who had a normal hemoglobin, was about to receive one, and thankfully stopped it in time. So this just goes to illustrate that it's those interactions also with the patient's notes and with their medical records, where you need to be doubly sure that you've checked you're dealing with a correct patient. Next slide, please. So just a brief word on patients whose identity we don't know. So all hospitals should have a policy which explains how they allocate a name to patients who are unknown. And that needs to be clear, unambiguous. It needs to remove any risk that there could be misidentification if there are multiple patients presenting together. And those patient ID checks are even more important where the patient can't advocate for themselves. So once that identity is assigned, those same ID checks between the wristband and any documentation being used have even greater importance. So I'll pass you on now for a transfusion practitioner perspective.
Thanks, Catherine. Okay, so as we know, as TPs, we know that there's areas that pose a challenge for positive patient identification. Next slide, please, Shruti. And these areas can cause issues because the patient isn't wearing a name band. So that could be your outpatient's clinic, or it could be that the patients can't wear a name band, which could be your dermatology patients, or it could be that your patients are wearing a name band, but we can't get access to it. And that could be in a major trauma situation, or that could be in a theatre situation or a cath lab. Next slide, please, Shruti. We also know that there's some patients that may cause some challenges for positive patient identifications, and those are patients whose first language isn't English, or we have patients with cognitive decline. And mentioned in the other slide, we also have obstetrics, so we have our babies and we have our paediatric patients. Now, as I've experienced myself, sometimes if you ask a small child what their name is, they might scream, "I'm Batman," and run away screaming in joy away from you. I do know that there is a paediatric session on basically this. So sorry, there is a paediatric session, and it is on the 19th of July. It's going to be a great session. It's on positive patient identification. If you haven't signed up, I would suggest that you do so. I think it looks really great. Next slide, please. So I'm going to go through 2 real-life examples of poor patient identification. So this was a busy accident emergency department. There was 2 males admitted minutes apart from each other, both similar age, similar build, both with penetrating chest injuries, and both were booked in as unknown. Next page, please, Shruti. And again. The consultant went and reviewed patient A and asked the junior doctor to organise some blood. The junior doctor took 2 samples 1 minute apart and took them away unlabelled from the patient bedside. The important part of this being that the junior doctor was only aware of 1 unknown patient. Next slide, please. So the doctor had left that patient circle and had taken the sample away. They labelled the samples up from the computer, and unfortunately they took down patient B's details. Processed the blood, sent it to blood bank, and the blood bank issued blood for patient B. Next slide. The porter delivered the blood to accident emergency, where the consultant had just got off the phone to somebody else and took the blood, and then asked the team who ordered blood for patient B, as it's not required. It was at this point the junior doctor realised her mistake, and thankfully the blood was returned to blood bank. Next page. And again, that's brilliant. So as we know, wrong blood in tube is caused by 2 main causes: failure to identify the patient correctly at phlebotomy and labelling the blood sample away from the patient. And we do know that 19% of the WBITs that were reported in this year's annual report involved both errors occurring together. Next slide, please, Shruti. Perfect. The next incident we've got was the hospital at night team approached the transfusion practitioners and said, "We've actually got a few concerns. We're seeing both patient transfusion samples being taken together. We are seeing no patient identification being done at venipuncture, and we're seeing pre-written and timed forms, and other staff groups are now being encouraged to take samples together. Can you help?" Next slide, please. So transfusion practitioners met with the hospital at night team, and quite quickly a short life working group was set up. And this was set up to look at this from a wider perspective. And the short life working group were looking at what changes in the process can we make to try and make things a bit safer. So they included QR codes on the request form. So when somebody requests blood now, they have to tick a box to say that they have done this in line with the second sample policy. And if they aren't sure on what that is, they click on the QR code, which takes them to a separate website, which talks through the second sample policy. There's also a change in terminology from second sample to confirmatory sample to try and, again, educate the staff on why we were doing that. The hospital at night team were empowered to stand up and say, actually, this practice isn't right. We think that you should be doing this. This is what we're going to do about it. We got extra education in, and there was a quality improvement project done in one of the wards to start off with, where there's a questionnaire sent out about second sample and their understanding. Then there was posters and some presentations, and then it was tested again at the end, and it was shown to improve patient safety, and that was one of the things that the TPs could do for positive patient identification. Next slide, please, Shruti. And how can your TP help overall? Well, we're here as your subject matter experts. We're here to signpost you to legislation or websites. We've got useful resources that you can use in your clinical area. We're here to do education and training, instant investigation support. We're here to help with positive patient identification, and we're here to help with all things transfusion. We're here if there is something that you need to escalate. We're here to talk you through the HTT and the HTC processes and for further governance. We're here for policies and guidelines. And we're also here just as a friendly ear as well if you've got any questions. We're here to help, and we hope that you use us. Thank you, and I'll pass you on to Dr. Davies.
Thank you very much. So I'm now going to talk about what patient identification looks like from the laboratory perspective. And of course, patient identification is different in the lab. We don't have the actual patient in front of us, but we do have the blood sample taken from the patient. So our patient identification safe processes all center around that blood sample, and it starts with the sample labeling. So we should all have protocols for accepting and rejecting samples based on the patient identification and other details on the sample and order, and whether that's a paper or an electronic order. And the BSH guidelines provide us with recommendations for safe practice in terms of minimum patient ID needed for sample acceptance. And this includes not just where ID is completely missing, but also mislabeling, such as spelling errors or missing numbers. And this is really important because mislabeled samples are 40 times more likely to be WBIT. And errors with registration of samples and orders on the limbs are commonly seen in SHOT reports. And unless you have a completely electronic system, then this is going to be a manual process, which is obviously at risk of transcription errors. And having duplicate patient records on the limbs is common, and that's also a risk for patient safety. And when making telephone orders, as mentioned before, we need to make sure in the lab that we're able to correctly identify the patient as well. It's really easy to mishear a name or an NHS number or a hospital number. And of course, there are direct impacts on patients if any errors are made in this part of lab practice. And these can result in specific requirements not being met or wrong components transfused, as seen in the SHOT chart here. And they can also result in what we call lab WBITs, where the sample's registered in the limbs against the wrong patient record. And this could impact not only patients needing transfusion, but also pregnant mums if the D types recorded is incorrect, so they may fail to get their fetal D-screening and anti-DIG prophylaxis as well. And in the lab, we do also need to consider the impact of sample rejection, and particularly where there's a major hemorrhage scenario and where rejecting the sample may actually cause a delay in transfusion. And we know from SHOT data that transfusion delays can result in patient death. So labs do need to have agreed procedures for dealing with mislabeled samples that don't cause delays when transfusions urgently required. So what can we do to reduce the risk of error in this part of the laboratory process? I've already mentioned the importance of sample acceptance policies and the zero tolerance approach, but we also need to make sure that we've got a capacity plan so we know what safe staffing level looks like to provide a safe service. We do need to make sure our SOPs are clear and they're understood by the staff, and that this aspect is included in staff training and competency assessment. Keep processes simple and include second checking where appropriate. If you can make the process completely electronic, then that's great, but it might not be realistic. And electronic systems for sample labeling can reduce sample rejection and improve patient safety, but only when they're configured and used correctly. And a 2-sample policy will reduce the risk of a WBIT resulting in an ABO incompatible transfusion. But obviously this does need to be supported by lab processes for safe release of group O red cells where we only have a single sample and there's a major hemorrhage scenario or transfusions needed urgently. So SHOT recommend looking for electronic systems to minimize manual processes wherever possible, but we do really stress that IET must be set up and used correctly to be safe. And we also know that interoperability between systems ensures that data is shared, which also goes to improve patient safety as well. So the next part of our lab process is the testing, the component selection, labeling and release. And we're still using our sample and now our limbs as well for patient identification. And using the same principles as in the clinical area, we're checking the patient ID again at every stage and every step or test that we do. And errors can and do occur here, as you can see in the SHOT chart. And if we're not carefully checking the ID on the sample and on the limbs, we can make errors in component selection. We can pick incorrect ABOD types. We can miss special requirements or antigen negative requirements. We could pick up the wrong sample for testing, or we could add the results to the wrong patient record. And when putting the compatibility labels on the components, we can make transposition errors or fail to notice patient ID errors at that stage. And again, these errors can have really serious consequences for the patient. ABO incompatible transfusions, hemolytic transfusion reactions if we miss antigen negative requirements. And errors that we make when labeling the components can also lead to delays in transfusion if they're identified in the clinical area and the components need to be returned to the lab for relabeling. So what can we try to do to reduce lab errors in this stage of the process? Well, for safe component selection, we would really want to look at our limbs to have algorithms and rules in there to support us and pick us up when we make an error. But other things are important here as well. Clearly labeled stock, having really clear and simple SOPs and staff training and competency assessment. And in terms of testing, we would really want to look to automate as much as possible with electronic transfer of the results. And where you do have to do manual testing, only doing one patient at a time and having a second checking process for that as well. And for labeling, again, if possible, using the LIMS or electronic blood management system to provide a label verification process. But if you don't have that yet in your labs, then SHOT do provide this really useful pause aid memoir that you can use instead. And the next critical step is in the collection of the component. And we're going to step outside of the lab now, really, because it's not normally lab staff that's doing this bit. But all of the patient identification and safety checks that we've done so far in the lab should mean that we've placed the right unit labeled for the right patient in the blood fridge. And patient identification at this step of collection obviously is not with the sample, but it's with a pickup slip that has the patient identification details on it. And this has been generated in the clinical area and brought down to the blood fridge. And we do see errors, obviously, at this stage as well. Incorrect patient details on the pickup slip, the correct pickup slip, but the wrong blood unit is taken from the fridge. And in some cases, emergency group O blood's taken instead of the component labeled for the patient. And again, these can have some really serious consequences. We've seen ABO incompatible transfusion where the collection errors have not been noted at administration. We see transfusion delays if the wrong unit's been taken and it's been noted by the clinical team and sent back to the lab, and then they have to collect another one. And components can be wasted as a result of confusion about what to do when the wrong one comes to the ward area. And we do see inappropriate transfusion of our precious emergency units as well. So what can we do to make collection a safer process? Well, again, really looking to IT here, and this is where our electronic blood management systems really show their worth. They alert the user and the lab to errors, both audibly and visually. The pickup slips can be generated from scanning the patient ID bands. And the new smart fridges, where the units are in individual drawers, means that the collector physically cannot take out a unit that's not labelled for the patient identified on the pickup slip. But if you don't have EBMS in your hospital at the moment, then SHOT do have this pledge checklist, which you can use as an alternative. So all of the checks, verifications and fail-safes that we have in our lab process, we've just talked about now, should mean that the component we've released and was transfused was recorded in our systems against the right patient record. And this patient identification chain is so important in terms of traceability. And whether your traceability records are paper-based or electronic, whether we're talking about emergency group O red cells or components labelled for the patient, components that are transferred to other hospitals, components that are used in the pre-hospital setting, and our blood products as well, we need to make sure that we can trace all of these to the patients that actually received them. And the impact of not being able to trace our patients correctly is that they may fail to get appropriate treatment for a transfusion-transmitted infection. Or maybe that we can't tell them that there was a recall on a component, but actually there's no need for them to worry about it. And of course, traceability is a regulatory requirement for transfusion, so we have to be able to do it. And we need to ensure that we can trace the fate of blood components for at least 30 years. And that's a really long time, during which we most likely have replaced our limbs. And so we do need to make sure that our mock recalls and our traceability audits include searching for component fates in legacy systems that we have. And also that their instructions for using those legacy systems are included in the SOP, because it's amazing how quickly we forget how we used the old system when we've moved on to the next one. And if we have paper records, then we do need secure storage. Scanning the records also provides a backup in case the paper records get damaged as well. And that's the lab journey. So thank you. I'll now hand over to Charlotte for the patient perspective.
Hi all, thank you very much for having me here today. Really appreciate it. So if you've not met me before, my name's Charlotte Silver, and I have a long standing history of receiving multiple blood products throughout my life. I've received a liver transplant back in 1996, and I have a rare chronic medical condition. So I'm really happy to be working with SHOT, not only today, but on a wide range of projects. For me, patient advocacy is critical to help ensure continuous learning and development and improvement, whilst I'm really grateful for everything you deliver to enable me to basically keep going and keep a normal life, so to speak. I do think there's opportunities for patients to feedback and learn and develop. And I'm pleased to work with SHOT in driving this excellence culture within the clinical community. So you may have seen this infographic, which provides opportunities for patient involvement. For me as a patient, it was interesting to see that in the 2021 SHOT report that patients should be seen as safety partners. I completely agree with this. Having had multiple transfusions, I know that there are lots of opportunities for me to communicate with clinical staff and for them to communicate with me and check, check patient identity, check the transfusion is appropriate and at the right speed, the right product. So within this, it shows the different opportunities for us to interact. So it may be me reviewing my sample, checking the labelling's correct. When I get my observations taken, there's another opportunity there for interaction. And for me, that's good patient care. I'm not just a number or a figure. I am an individual receiving a treatment that, although it might be a regular treatment, it's still quite anxiety inducing, and it can be quite difficult to raise a concern. So all these opportunities within the transfusion pathway offer up a chance to deliver that good patient care, but also deliver, make sure that the patient is safe. So you would have maybe come across this graph as well. For me, the 10 steps in transfusion are those critical points where we can have those positive interactions, as I mentioned previously. This is where, for me, I would be concerned if my identity wasn't checked. And sometimes if I'm conscious that maybe somebody hasn't confirmed my date of birth or my name, I will say, oh, would you like my name and date of birth? Or rather than, whilst there are many benefits to electrical labelling, I guess for me as a patient, sometimes that can feel a bit removed. So whilst I'm reassured to have that electronic labelling, because I know that things can be traced throughout the process, I still need that human interaction. You know, how was your day? How are you feeling about your transfusion today? Do you have any questions? Rather than simply lifting up my arm, scanning my wristband and continuing on with the day. We know that when mistakes happen when these things aren't followed. And I think for a patient, it's nice to feel involved. You know, it can feel like you're having something done to you, but if you get a chance to cooperate and feed in, then it feels less, you've got a bit more control. So we know that mistakes happen. I've seen that. I have questioned before when the blood wasn't the right mix for myself, and generally on the whole, people are very receptive. They will go away, look into it, feedback, which I really appreciate. I think there's a certain level that you need to be honest with the patient, but to an extent, the patient just wants to know if there's an issue, how you're going to resolve it. So for me, like that patient involvement is more around the opportunity to ask questions and clarify their treatment. If those opportunities aren't available, it can be very intimidating to raise your voice and raise any concerns. I know, having worked with SHOP, that haemovigilance is so important, but if it's your first time receiving a transfusion, you may not know what to ask. So I think that's why the visual graphic here is so is really important for patients like myself to explain why you have to have that check and why you should call out if you haven't had that check. As I said, you can feel very vulnerable as a patient. So I like to think that I'm trying to advocate on behalf of other patients. And this comes back to a culture. So quite often when we know that the NHS is really busy, there's staff shortages, etc. But when I walk into a ward and, you know, maybe I'm not greeted, or there's, you know, I'm just sort of pointed as to which bay to sit in rather than explained, oh, hi Charlotte, how are you today? You feeling, you know, do you have any concerns? Here's your bed, but we'll come back soon to do your ops, etc. That reassuring culture, you can almost feel it as soon as you step into a ward. And if there's that reassuring culture and everyone's talking to each other, I feel much more secure in my treatment, knowing that actually if an issue does come up, there's the openness within the team for maybe a more junior position to question a more senior person, or whether the senior person, you know, is taking care of their team. Because what I wouldn't want to happen is the hierarchy within the team structure actually reduce the chance that an issue is taken seriously or it's not flagged up. So yeah, thank you very much. Yeah, I was just going to say teamwork helps build that, and you really pick up as a patient on that. You have a lot of time to sit there and watch the team. So after about 6 hours, you've got a good sense of what's happening within the team. But thank you very much for listening to me. I look forward to any questions at the end.
Good afternoon, everyone. I'm Davidson, and I'm going to give you a bit of a quick tour of some of the resources that are available to help you to get this right. But I would encourage you to look locally. There'll be numerous resources that are provided by your TPs and the transfusion teams in your local organisations. Thank you. So there are checklists, flow charts and pathways. The example here, of course, is the SHOT checklist, and there is a link there as well, a QR code that you can scan that. The next slide. But there are also here, there is a flowchart from Northern Ireland, and also a care pathway from Scotland as examples of the tools that we use. Next slide, please. There are also screensavers and posters available to help you to get those messages out around those clinical areas, and they can be suitable for both staff and for patients. And this is another example of a poster. There are also flyers and presentations. You may be familiar that the SHOT website has lots and lots of resources to help you with these, and may be suitable for conferences or educational sessions, for example. And then there are videos and animations, and these can be in the form of step-by-step guides to the processes, or they might be a comedic representation of what happens when things go wrong. But they're useful for people who learn in different ways. E-learning is available across the UK, and depending on which country you're based in and which organisation you work in, will determine which programme you have access to. And this might be on TORAS, e-learning for healthcare, ESR, e-integrity, or LearnPro. There are also apps available that are there and designed to help you at the time of the transfusion. So at the patient's bedside, you can use them as an aid memoir to help you with those positive patient identification steps. They're available to download from both Apple and Android, and there is also a web version available to facilitate education. Also, we would suggest using signatures and taglines. These can help with maintaining that subliminal messaging and, you know, maintaining that consistent message in your teams. We would encourage you to download the SHOT app. Extensive resources are available from it, and it can be downloaded from Apple or Android via the QR codes that you can see on the screen now. And also, as was mentioned earlier, we do have another event next week on Wednesday, the 19th of July, between 1 and 2, with a focus on positive patient identification in children and neonates, and the particular challenges that are faced in those patient groups. Now, thank you for joining us today, and we would like you to take on 5 key messages. 1, don't assume that somebody else has done any checks. Don't assume that they've got it right, even if they have performed a check. Check for yourself and check again. Involve and empower your patients. Give them permission to challenge your practice, but treat them as an individual and listen to what concerns them. Zero tolerance is a really key part of the safety culture. So think about that's why those policies are in place, and think about how you label your samples. And finally, remember that positive patient identification is important for everything that we do in healthcare, for every interaction we have with our patients, not just for transfusion. Finally, we just wanted to express our thanks again to all who have contributed to SHOT reports, to recommendations, and to this webinar, and in particular to those groups that I mentioned below. Thank you very much.
Thank you all for these very interesting and important presentations. Hopefully there's a lot of questions and comments from our attendees. We are now moving on to the Q&A. So one of the questions is how do we get access to the posters and screenshots? Shruti?
Yeah, I think we can put all the links in a document and then release that when the webinar recording is released, because I think there are compendium of resources from all the other countries as well. So I think we'll put the list of the recommended resources. I think Anne had already done a great job of compiling them, so we'll just put them in an accessible format.
Thanks for that, Shruti. Paula, a question probably for you that someone's asked a question about, is the name enough? when you're identifying the patient at the bedside or the patient's side? Should we not be doing anything more than just the name?
The name is absolutely not enough, because there are lots of reasons. There are quite commonly patients who've got the same name, or assumptions are made about how the name is spelt, so it actually isn't the patient that you want. So you've got to have the full identifiers. You've got to have a date of birth and a hospital or some sort of identification number. Otherwise, it's just not safe. And there are numerous examples in 25 years of SHOT reporting to show how what the risks are. And I did put in the chat that the case, which was somewhat amusing, where we had adult triplets who all lived at the same address, who all had the same surname, the same date of birth, and the only thing that differed was their first name, and they all had the same initial. And hospital staff, seeing to one of the three adults, had picked the wrong one, and it was the patient who said, "I don't think you've got the right record." So I think that when I started working with SHOT in whenever it was, 2011, the thing I realized very early on, that it's so dangerous to make assumptions. And it's assuming things, like assuming the previous step was done safely, or assuming that you know how to spell the patient's name, that lead us into deep trouble that at worst can be lethal.
Thanks, Paula.
Thank you. And do feel free to continue to type your questions in the Q&A. There's no question that's silly at all. So if it's absolutely anything, please do feel free to type that and ask. A question that we've received was, how can I empower patient empowerment during the patient identification process? So I don't know who wants to take that on. Kath, maybe?
So I think there's an aspect of creating a culture where patients expect to be involved in their care, and we should all be aspiring to that. But particularly if your unit can encourage that, like Charlotte was saying, to involve the patient as they step through the door, and to make them feel that they are an individual. And then encouraging us being the ones to offer, well, would you like to check your sample? So that people don't feel awkward to ask. And then if you do that once, then the next time they're admitted or the next transfusion they go to, they may feel empowered to say, oh, yes, can I check my sample? Or as Charlotte said, would you like to confirm my name and date of birth? And so it's as much needs to initially come from the healthcare professionals first, so that patients can then see that that's part of the culture.
Thanks, Kath. Charlotte, did you want to add anything to that?
Yeah, I think I would completely agree with that. It always really probably starts within the first 5 minutes of any appointment, you know, of walking into the centre, like I said, or even at the phlebotomy or blood test side, like I said, checking the sample. I think it's just about the education of, like, how can a patient be involved, and that might be discussed with the doctor or something if they're about to embark on like, you know, feel free to ask questions at any point in the process, not just the start. And again, it might seem like repetitive, but after each thing, you know, after the obs, after the blood, you know, when they first come in, do you have any questions? Do you have any questions? Because sometimes you might not have a question that minute, and then 15 minutes later you have a question, but then you don't want to go up to somebody and ask. So I think there's always opportunity to say, do you have any questions?
Okay, thanks,
Emma,
Charlotte.
if I can just add
sorry.
as well.
Yeah, sorry, I didn't see your hand. Yeah.
No, that's fine. I think even Paul also has a with this one. I think it all comes back, I think, as Kath and Charlotte have said, it is actually in the safety culture, and it is. We've already emphasized that this accurate identification is necessary for all aspects of the patient care. So I think making it first, it also should actually begin by introducing yourself as well as a healthcare professional. When the patient walks through, you're breaking down that barrier and then introducing yourself, creating that. Okay, please do. You know, all suggestions, comments and queries are actually welcome. And I think it is that, as Charlotte said, the first 5 minutes and at every point of the contact with the patient. And, you know, all of us have accessed, you know, I myself have also been I'm a patient. you always, get that feeling when you're made to feel at ease, and so that you can feel empowered to even comment. So comment as well. So it is not just active, but also the tacit behaviors, as well as the conversations that go on within the team. So I think it actually comes from actively trying to involve the patient. It doesn't naturally just happen. So I think we all as a team should be actually doing that.
Paula, did you want to come in?
I just wanted to pick up something that Charlotte's mentioned before, maybe not today, and that is, and I know from my own experience, that when you walk through the door as a patient, you don't feel empowered. You feel that you're going to have things done to you. So it's actually much more, you're not actually relating on an equal footing, even though we may think that people are. And it's really important to add to what you've said, really, to encourage us as patients to be involved. But I think people are scared to get involved in case they say something wrong, and then they get hostility from the medical and nursing staff. There are all sorts of barriers there that I think we don't appreciate until we're lying on a bed.
I think there's a position, clinicians are in a position of power, aren't they? And, you feel very much like your patient care is being done to you, and like they're doing the best they can in the circumstances. So there's that power imbalance already in a way, although maybe clinicians feel like the patient is in a position of power. Sometimes from the patient point of view, we're not in a power because we don't have any choice. This is being, it's unlike, well, we may have choice, but it's usually very limited choice. And so I think that power imbalance can sometimes say, like you say, getting up on a sort of level pegging by just introducing your name, having that culture just helps reset that power imbalance sometimes.
Thanks, Charlotte.
So there's another comment on our Q&A. It says, I agree that name is not enough. Also, repeating identification steps is best practice, even though it has been done by someone else in the team. I normally just tell my patients that even though someone has already gone through this step, I have to repeat this step to make sure that I have positively identified the patient myself. Assumption is a recipe for disaster. Anyone care to comment, please?
I think on that note, I wanted to ask Charlotte, actually, how does it feel like a patient when, I think in one of our conversations, you had actually mentioned, don't the team members talk to each other? So, if within your span of a couple of hours, 3-4 individuals are coming and asking the same thing again and again. How does it feel, when you started, and also now when you're actually more informed, how does it feel as well?
Yeah, now I'm more informed, it definitely makes sense. But I'll be honest, like sometimes it has felt like, why are you disturbing me again? I'm trying to nap or read a book or whatever, and like you say, don't you it's only a small ward, aren't you all talking to each other? Because then that could make me feel nervous that actually no one's talking to each other. But once it was explained to me, like we each have to identify you at each point, just to confirm that this is safe for you, then that's fine. But yeah, initially I was like, what, because in a course of, like you say, 4 hours, you might be checked by four different times, and it's not like you're moving anywhere. I physically can't get out of my seat, so it's not like we've been playing musical chairs or something. But, yeah.
Paula, you've got your hand up there.
Yeah, I think it's really important to explain to patients why we're doing it. And we've certainly had at least one instance in SHOT where, after being asked several times, the patient deliberately gave a different name and date of birth because he was so fed up with being asked.
Yeah, it's shocking, isn't it? We've got a question here from Julie Edmonds. Hi, Julie. Nice to see you. We constantly strive to educate staff about the risks involved, but despite knowing the risks, we still label away from the patient's bedside. We share the incidents and things, but how do we change the culture and sustain this by checking by the bedside? I don't know if April may be able to answer that one, being a TP. I don't know. Just thinking. Anyone?
I can make a start, and April can.
All right.
I think it comes back to what Paula was saying. Do we actually understand the why for the actions that we are doing? And I think, do we understand the implications? Because, it can result in a potentially fatal ABO incompatible transfusions. And that makes an importance of every little action that we take now, as we said. So understanding the why. And the second is actually also looking at why those workarounds are in place. So if people are doing it away from the bedside, we have seen certain system level, the way the ward is designed, the way your setup is designed, that there is no space by the bedside. Or we've also seen practices during the COVID time, because it was the, doing it outside the patient side, that is being embedded, and they're not going back to what is actually the safe. So I think it is understanding the why, making sure that you understand the reasons for these workarounds, so that you're actually making it easier for people to do the right thing. Sorry, April, you can actually add to that, please.
I was going to actually say about making it easier for them to do the right thing. I suppose it's exactly what you're saying, Shruti. It's working out why they're breaking the process that should be happening. Why is it that it's easier for them to break the process and to actually follow it? I think education and training is definitely important. Retraining as well, if there is an incident, and looking at the human factors. It's the human factors as to why this is occurring in your area, why you're seeing this. I wish I had a magic wand to fix it. We've been talking about this for about 20 years now, and we're just not getting any further forward with it. So I do wish I had a magic wand and tell you the fix that should happen.
Thanks, April.
Thank you, April. Oh, the questions keep disappearing. So there's one here, just a comment really from Biddy Riddler. Just a comment, please. It's also important to target trainee staff, medical and nursing students before they are professionally qualified. So I don't know if any of the panelists just want to comment on that as well.
Kath, why don't you go first?
Just, I admit to my embarrassment that I don't think that I understood at medical school. I thought those OSCEs I was talking about was just an annoyance. It's like, oh yeah, you get your marks for, you go in, you wash your hands, you introduce yourself, you identify the patient. Oh, good, I got the marks. But I didn't understand at a deeper level the consequences of getting that wrong. And so it goes down back to what you were saying about not only teaching something, but not just the what, but the why. Yeah, if I'd had some of those case studies at medical school that we present today, I think they'd have stuck with me into my professional life rather than having to encounter them from the incident investigation end.
Thanks, Kath. Shruti?
I just wanted to say that the training is getting more and more diluted and abbreviated. And I think so I think it is really important to maintain focus. This is a very important aspect of patient safety, not just for transfusions, but for medication safety and all aspects of care. So I think I completely agree, that the teaching has to actually go right at the undergraduate level as well. And I think in the nursing, medical, scientific training. So I think it's really, really important for that.
Okay, just quickly to finish off with Anne before we move on to the poll. Oh, sorry, we may have time for April, sorry.
Oh,
no, go on, Anne.
Totally agree. And, I would be encouraging the conversations that I have with universities about undergraduate education is consent perhaps should, and patient identification should be the first things that people learn about when they step through the door. Patient identification is the key to all patient safety, no matter what you're doing to them. And therefore, it has to be the single most important thing that we do.
Okay. And April, this is going to have to be the last answer. Thank you.
That's fine. In Scotland, we have actually just reviewed the undergraduate training for our medical staff and our nursing staff. So hopefully we should start to see a bit of an improvement in Scotland. We became more involved. The TPs are now doing sessions with both groups of staff. So hopefully we should start to see a bit of an improvement. Thanks.
Thanks, April. That's great. So for everyone that's a delegate and participating and watching today, thank you. We're going to pop up a poll on the screen now. It's only a couple of questions. It will take just a moment to answer. We're very grateful if you would. It's a feedback poll and just to give us information about yourselves. If you wouldn't mind, that would be great. And just really to say thank you to everyone that's participated today, the speakers and yes, the delegates, of course. And we're really grateful that you've made the attempt and made the time to come and watch us. We've got the paediatric webinar on the 19th, as someone have mentioned earlier. And also, if you haven't had your question answered or you do have any burning questions for SHOT or for any of the speakers today, please email us at SHOT or add an email into a question into the chat again, and we'll endeavour to answer that if we can in coming days or weeks. Okay, so that just remains to say thank you very much to everybody. Shruti, do you want to have a final word, or is that okay? You okay with everything there?
No, that should be fine. Thanks very much, Simon. I think also to promote the second webinar that we are having on the patient identification, and this is in children and neonates, and where we would cover all the particular challenges as well. So please to join us on the 19th and share the webinar recording that will be available on the SHOT website with other members of your teams who may not have had a chance to attend this in person, I mean, in live.
Thank you very much, everybody. So thanks a lot, everybody. Take care. Bye-bye.